a little bit jarring because I had no intention of helping anyone, right? The idea was to just be this unobtrusive fly on the wall that collects data, certainly not affecting someone's experience, but time and time again, the folks in the clinical samples would say things like that, things like, it caused me to pause and introspect about my symptoms, it caused me to think about my relationships, it caused me to wonder if I can do this, what else could I do? And I couldn't ignore that, right? It just kept appearing again, and again, and only in the clinical samples. The healthy controls were happy to take the compensation and leave the device and go on their merry way. And so that experience stuck with me, and I couldn't help but think that if we're able to get these anecdotal improvements in how people feel when we don't even want to do that, what happens if we actually put our minds to it? And so right around then, that's when mobile phones hit the scene, or especially smartphones a few years later hit the scene, and the field exploded since then, right? And so it's a combination of things that I was naturally running into in my area of research, originally being a bit technophobic, and the natural evolution of the technology and the commercial aspects of this that we try to piggyback on creatively, and in some cases pushing the technological envelope. Okay, so before I get into mHealth specific things, because you're a diverse group, I thought that I would use it as a bit of a soapbox to tell you some thoughts. One, let's think about how we know what we know about therapy and how we know what we know about mental illness, about the very nature of psychopathology. So if you're thinking about therapy sessions, meaning that interaction between a person and a person in a clinic setting, where they do some sort of interaction that is supposed to carry out for the remaining 23 hours of that day and the remaining 6 days of that week, that is 19th century technology, right? That approach emerged in the late 1800s, and we've had variations on exactly what we do over the course of that session, but it's really based on the capacities that we had back then and there. But we're not limited anymore, right? We don't have to have that in-person interaction and assume that what we do in that focused artificial setting is the best way to intervene with what someone carries out into their day-to-day life, where they encounter their real challenges and their real relationships. And that's not to throw the baby out with the bathwater, right? It just means that the very way that we think about what our points of intervention and what the format of intervention might be can change over time. Schizophrenics versus people with schizophrenia. What's the difference between those two? Right, so people first language, that's not just PC stuff, right? That speaks to the core of how we think about our research participants and about the illness. So when we call someone a schizophrenic, unlike many other disorders, but other disorders are highly stigmatized as well, we are plastering that as their primary identity, meaning we don't see that person as a person who's a father and a gardener and may have diabetes and has complex relationships and has other strengths that we can build on. We first and foremost see that schizophrenic experience, and given how most people think about schizophrenia, it paints the entire experience of it. And if you think about the inclusion-exclusion criteria that you see in most studies, it's perfectly acceptable to have a study that's focusing on cancer or HIV management or gaming addiction that says we're very inclusive. We include everyone, aside from people with schizophrenia and bipolar disorder. That's a given. Why is that a given? Why is it a given that we systematically exclude an entire group of people who have very much the experience that we're targeting, who could probably benefit from something like anxiety interventions, new couples therapies, anything and everything that we offer in the context of biomedical care, because we are indoctrinated in graduate schools to be very fearful of this population, this unique population. They're not so unique. They're human beings just like everyone else. They come with the complexities that everyone else comes with. I think it's that lack of familiarity and this notion that somehow they are a completely different subset that perpetuates these cycles, and that's super problematic. An extension of that is also saying things like, that person is delusional versus that person might experience dysfunctional beliefs. And that is where this starts intersecting with mobile health as well. So delusional, when you say someone is delusional, it's very easy to ignore everything that they say and do. Right? That paints your entire experience of them, because that person is in a fixed state, right? It's constant. But if they experience dysfunctional beliefs that ebb and flow, that might be contextually impacted, that sometimes might tip the balance into something that is really resistant to evidence, that you might even label a delusion, but most of the time they're actually thinking quite logically about most things, then that changes how we might approach interventions. And linking back to that 19th century technology of therapy, now we have the capacity to ask people or see what people are thinking in the moment and see whether delusions are actually chronic and static like that, or whether they change over time. And they do. So if you look at research that is emerging using mobile technologies about hallucinations or about delusions, you see they are not constant. They can certainly be contextually triggered or intensified, or there can be preventive factors. And so it creates the fact that we are taking different levels of abstraction in the way that we think about the symptoms and the illness gives us new opportunities for intervention. And I'll give examples for that in a moment. So again, this is just to revisit that part. For those of you who don't do research in mental illness, really think twice and three times about this notion of excluding people because of the perceived risk that you think you might have with certain diagnostic groups. Okay, so back to mobile health. If we're looking at penetration of mobile cellular infrastructure and phones over the last 20 years or so, we've seen this explosion, right? If in 2001, the estimates by the UN are about 1 billion worldwide, at the end of 2017, the estimate is that it exceeds 7 billion. Now, of course, this doesn't mean that every single adult, every single person on the planet has a mobile phone. Companies have more than one, people have more than one. But by and large, it means that the vast majority of the world's population now has access to a mobile phone. And think about the healthcare implications of that. More people have access to a mobile phone than they do to a working toilet or use toothbrushes. Yeah. So my question, though, circling back to these populations that I'm interested in, people that we know that are often marginalized, have limited access to resources, do people with serious mental illnesses use mobile technologies? Or is there some reason to think that they are different from the rest of the population? And meaning that some of the interventions that we design for them need to be unique. So to answer that question, back in 2011 and 12, and I say back then because in our world, that's a lifetime ago, right? So we conducted the first large survey looking at the penetration of mobile devices in people with serious mental illness. Close to 1,600 people who were getting services from community agencies scattered throughout the greater Chicago area. And so this was not an especially technologically savvy group. They were very representative of the population served there. 50% of them lived in some sort of assisted living facility. Medicaid recipients earning $10,000 or less a year. So exactly the kind of folks that I was interested in accessing. And we found that even back then, 72% of them had a mobile device of some sort. They were using it for all the things that people use mobile phones. So people were calling and texting, and a third of them were emailing and using the internet. And so that suggests that even back then, they had smartphones already, which were really cost prohibitive earlier on. And those findings have been replicated again and again in subsequent research. So studies conducted in Baltimore and Boston show that the penetration rates are anywhere between 86 and 97%. Research conducted in India shows that 72 to 92% of people with schizophrenia have mobile phones. When you look at different regions in the US, 2/3 now have smartphones. And a study that we recently completed with a more selected group of people we recruited through Facebook who hear voices. So again, probably a more technologically sophisticated group and probably a younger group. But of that group, 92% of them had smartphones. So to answer that first question, absolutely people with serious mental illnesses have access to phones, are using it in creative ways. It really creates this opportunity to leverage this penetration for mobile health interventions. So let's talk a little bit about what that might mean. At its most basic form, Really, we're not creating new technology so much as repurposing existing technologies like texting to provide mental health support. So let's not knock texting, right? That can be a very powerful intervention for some people. It gives you the capacity to have asynchronous but continuous conversations, which can really be helpful in managing certain conditions. And I'll give examples from our program of research for each one of these. So then as we ascend up this evolutionary ladder of technological sophistication, that's when we start going into things, into interactions that the human is a little bit more out of the loop, automated interactions like app development, right? And so our team has developed several apps that focus on managing serious mental illnesses. These are very overt and visible. It's very clear to the patient that they are interacting with something that is asking them about how they're feeling and functioning, and based on their responses, they get content. So it's not quite a session on the phone because we don't try to transport a 45-minute psychotherapeutic session onto a 2-minute exchange. We modify content, we distill it to what we think are the most potent nuggets of intervention, and we might deploy them multiple times throughout the day and throughout the week rather than in a condensed 50-minute interaction, right? Nobody uses their phone for 50 minutes straight doing one thing and staying focused on it. But again, it's very overt that that's happening. But we've also continued to trace into this area of behavioral sensing and signal detection and predictive modeling. And there, the idea is to try to capture the digital behavioral indicators of when someone is not feeling well, right? So what can we capture from GPS and accelerometry and light sensor and audio and all these other things passively? Now, again, not in a covert way. People know that we install software on their devices and they're happy to be partners in these projects with us because they know that our objective is to try to improve their outcomes. But for the most part, the software, the device collects data on the fly as people go about their daily life, and we don't do much unless it's time to do something. And again, I'll give you an example for this in a moment. Okay, so let's start with what a person-to-person repurposing of technology for clinical interventions in mental health might look like. And so this is a model that we call the mobile interventionist. This is how it works. So a community-based case manager does a home visit with someone with psychosis and co-occurring substance use. That's a group that's known to be especially tricky to engage in services long-term. And so there, she, in the case of this study, will identify the most viable treatment targets. What are the things that you need extra help with? What do you want to work on? What is our team not addressing well enough in our face-to-face interactions? And so they'll decide on starting points, on targets. If the individual doesn't know how to text, right then and there, she will work to train him or her how to text, and they'll do some mock runs in the room to make sure that they know how to hear a prompt, how to respond to it, how to type a message back. So by the end of that 1 hour, they're good to go, usually. And once the mobile interventionist leaves the home, the exchanges start the next day. And the idea is that there are these ping-ponging back and forth interactions that can stretch out throughout the day. And there's something very unique about text that doesn't seem to appear in any other form of digital communication. The conversation can start at 8 a.m. and continue seamlessly at 11 and continue seamlessly at 2, and no one bats an eye. And we leverage that, right? Because we know that the clinician can't just wait there to get the messages and respond in the moment, and it's perfectly acceptable to participants that they might hear in a few hours, or if they send a text message after 5, they're going to hear the next day, and if it's Friday, 2 days later on Monday. So people are accepting and are socialized to expect what they will get from the mobile interventionist. Usually at the end of the week, the MI will send a summary email to their treatment team, giving them some insights about what happens over the course of the day, and if there are things that they need to act on. If there's something time-sensitive that emerged here that they really do need in-person support. And the idea is that this facilitates the team and patient interaction. Okay, so these are actual text exchanges from our first study in the mobile interventionist. Hi, it's Sarah. how are you feeling, Ray? And so Ray says, and so we really just copied it right out of it, so there might be some grammatical and spelling mistakes. Hi, Sarah, voice is talking about me. So this person has auditory hallucinations. Sarah knows this because that's something that they discovered during that first home visit. So not surprising to her. That's stressful. You're not alone normalizing the experience. Lots of people hear voices. But Ray is focused on the fact that they say something is bad is going to happen to him if he takes the bus. So Ray is giving her a target, right? He's giving her a very specific opportunity for intervention here. So Sarah starts with the 1-2 punch. But voices make mistakes all the time. I have a trick that can help you test your voices. You can even use it on the bus. So she's really grounding this with his personal life experience, right? The place and the context that he said that is troubling. Do you want to hear about it? And Ray gives a semi-enthusiastic maybe. What is it? But that's the window of opportunity that we're waiting for, right? It's that opening to be exposed to some sort of, in this case, it might have been a relaxation strategy. She coordinated a time where she would text with him while he was getting on the bus to a community center, giving him supporting messages and guidance as he was doing it. And we got Ray back on the bus. So Ray returned to do something that he was not doing as a result of a specific psychiatric experience, and we were able to support him in real time using this approach. And so at the end of a 12-week trial with people who, again, had the diagnoses that I mentioned, they were not a high-functioning group, people that at baseline had moderate cognitive impairments and moderate psychotic symptoms and moderate depression. 80% of them were people that were hospitalized 6 or more times previously, so people with psychosis and co-occurring substance use, that's not surprising. Only half of them reported ever having experience with texting. So that texting piece, that training in the beginning, definitely was necessary for them. And to help understand these findings, in terms of feasibility, we had 0 dropout. So every single person that started the study completed it, which in a study with our population is almost unheard of. They received about 140 text messages. The response rate was to 87% of those messages. Again, in terms of engagement, almost unheard of. In terms of satisfaction ratings, people were pumped about the study. And in terms of clinical outcomes, we had at least 2 reported events of suicidal ideation. Through quick responses by the mobile interventionist, the team stabilized those individuals. We had another person that didn't say, I'm going to the hospital, but had a pattern of not taking medications, not sleeping, and not eating, which was very similar to the pattern that wound up bringing her to the hospital previously. She was stabilized, and we had changes in the typical measures of psychotic symptoms and depression. But that really wasn't my question for that study. My question was, can we establish a therapeutic relationship between a person and a patient entirely via text? Because outside of that first meeting, they don't see Sarah at all. It is entirely conducted via text messaging. So we administered the Working Alliance Inventory. It's a measure of the therapeutic relationship between patient and provider. Basically, it asks, are we on the same page? Do you respect my experience as a patient? And so we asked people to fill this out twice. Once rating their in-person clinical team, which in some cases they've been seeing for the last 8 years, and once to rate Sarah, which they just met 3 months ago and have only been texting with. And so the ratings for both of them were very good. The ratings for Sarah were significantly better than they were for their clinical team. So can we establish a therapeutic relationship entirely via text? Absolutely. Even with people who have never texted before. Okay, picking up the pace here. So on to that second type of intervention, these automated interactions, software. I'll tell you a little bit about Focus. It's a smartphone app that we developed specifically for people with serious mental illness, and it's a program of research that's been very fortunate to benefit from a lot of funding, so we were able to refine and improve it over time. It's probably the most mature mobile health intervention that we have in our arsenal right now. Our team has in its arsenal. And so it started with a needs assessment where we surveyed over 900 people with psychotic disorders to see what are the viable targets for you? What are we not getting at with clinic-based care? We also spoke to practitioners. What do you need help with? We also spoke to community mental health center leaders. What are the kinds of things that eventually might be acceptable to work into your workflow? What might not be objectionable? So we don't want to develop something that is totally out of the realm of possibility. And then we brought together our multidisciplinary team. Again, as we know from this institute, it's impossible to do these kinds of things just as a single. The days of a clinical researcher sitting and sort of coding something together for a PDA, which is really the extent of my capacities, they're long gone. So the more sophisticated your tasks are, there's no way that you're going to do it on your own. And so I was fortunate enough to work with David Moore's group at Northwestern. I think I was one of the first people that their center took on as a partner / client / partner. We developed the content together. We did the programming, again, with input from patients and providers. And then we did lab-based usability testing. Right? So we brought people in to do think-alouds in the lab to tell us about their experience of the look and the feel of the user interface and content. And people would say things like, oh, this is terrific, I don't understand what this is, or you can just see by the amount of time that it takes them to negotiate the screen that we are not doing a good job in helping these people navigate. And so we refined and refined and refined and refined until we thought that we have something that is ready to go. And so that's what that is. So this is focus. The way that it works, it has 5 treatment targets: voices or auditory hallucinations, social functioning, which really means social skills training and content focusing on paranoid ideation, medication use, sleep. Sleep is not a core symptom of schizophrenia. Time and time again, those interviews with patients told us sleep is a huge problem. Sometimes sleep is an early indicator of when I'm going to feel bad. When I have symptoms, my sleep gets messed up. If I'm tired, everything else goes down the drain. So it was clear to us that we need to add that as a target. That wasn't what part of the plan going in. And mood, which really means depressive or anxious symptoms. And so focus will prompt people up to 3 times a day, but all the content is available on the device 24/7. It's a native app. It doesn't require internet connectivity to access the content, so people can launch whenever they want. Focus prompt will take over someone's home screen. It'll ask them if they want to engage. If they do, it'll immediately assess the target area that was designated for that time frame. So that the first question for Rachel, who hears voices, is, have you been bothered by voices today? And Rachel says, yep. And so then it hones in on what might be the dysfunctional beliefs that Rachel might have about her voices. That's our target in cognitive behavioral interventions for psychosis. And so these are common dysfunctional beliefs. My voices can't be controlled. They know everything. They're powerful. They're unpleasant, or something else, right? Because we can't capture everything. By the way, there are multiple versions and permutations of the wording. So even if it gets at the same underlying construct, they don't always see the same words. Right? So it helps keep things a little bit fresh. Here, Rachel says, I think my voices know everything. So focus starts launching with those distilled interventions. They can be a sequence of screens. So most voices may sound like they know everything, but they don't. Can you think of any time when the voices made a mistake? How about when the voices were sure something was going to happen, but it didn't? If the voices got it wrong once, they probably don't know everything, right? Think about it. Now, if you look at the screen, it is a very simple screen. We really intentionally tried to keep it down to a sentence or 2 max. There's only one direction of the flow. This was not how we started. We started with fancy bells and whistles and realized over time that we were really not connecting with our target audience who might have cognitive impairments and other issues that all just make it confusing. Create one direction of flow, make it impossible for people to get lost. So in addition to the written content, we also have video versions, video and audio, right? So we're leveraging the full multimedia capacity of a smartphone, because otherwise we're just giving people handouts, right? And so if they endorse voices and they select the video options, they might see something like this.
experiment to test her. Ask her to make a prediction. Color of the next 3 cards that you see. Write down colors and the order was the same. Now, ask her. Are the next 3 cards exactly the same order of colors as you mentioned? If they got it wrong, think about it. What else could the voices be doing? The predictions are not always right.
So they have an arsenal of over 160 of these, right? Quick and dirty intervention strategies that are at the cognitive level, that are at the behavioral level. Depending on what they choose as their problem, it'll take you down this choose your own adventure pathway into something that ideally is at least semi-tailored to what you need in the moment. We also have a clinician dashboard, so all the responses to these assessment questions are uploaded to the secure server when there is internet connectivity, and that gives you a good snapshot to whether it's the clinical researcher or community-based worker that is given access to this, to see how this person is doing. What are the treatment targets that are assigned to them, sleep, mood, and medication. And again, this is not designed for a broad audience, right? This is, researchers can make use of it. When this will be adapted to real world care, it needs to be much more visual, right? Less with the numbers and something that will grab your attention immediately. But we also have a breakdown of the severity of symptoms, and we can chart people's progress over time. Okay, does it work? All right, aside from the fact that we can pull it off and we can make it feasible and acceptable. So the first run of Focus, we deployed it for 30 days, right? A 30-day field trial, again, with a sample that's representative of the folks that we're typically interested in targeting with this. Over those 30 days, participants used Focus on 86% of the days that they had it. In the first week, they used it on average 6.4 times a day. In the last week, 4.9 times a day. If you recall, we only prompt people 3 times a day. So above and beyond, and there's no incentive to use it more, right? People don't get paid. People get paid for their assessments in the study, not for their engagement in care. They could not use it for the entire month. They'd still get paid. And if people elected to use this above and beyond what we prescribe, 2/3 of Focus use is typically on demand. So when we administer usability and feasibility assessments at the end of it, people would recommend Focus to a friend. They didn't think it was complicated. They thought it was interactive. They felt confident using it. They didn't need to learn a lot of things before they could get going. That one was especially important for us. It was easy to find the information that they needed. In terms of clinical outcomes, again, significant reductions in symptoms of psychosis and in depression, which, by the way, in terms of effect, the magnitude that we're seeing here is comparable to highly potent in-person 24-week CBT for psychosis when it does work. And so we're getting the same type of outcomes here through the smartphone intervention and a weekly call from someone to do technical troubleshooting and some hand-holding, which usually lasts anywhere between 5 and 10 minutes. Okay, since then, we've also deployed Focus as part of this multi-state relapse prevention program. It was very interesting to see that the same demographic variables that predict engagement in clinic-based care also played out in how people engaged with Focus. So female participants engaged a little bit more than males. White participants engaged a little bit more than African-American participants. Older participants, meaning 30 and older, which is depressing, but 30 and older participants engaged more than younger participants. But in all these cases, not by much. And in fact, if you look, in the deployment period was quite long. So if you look at study weeks, we had Focus up to 6 months. The red line represents 44% of the sample that basically were using all Focus functions pretty regularly throughout that period. 6 months. Okay, last step in the Focus program of research, we just completed a comparative effectiveness trial in the last year, comparing Focus to RAP, which is a more traditional clinic-based group intervention. So that means that people come into a clinic, you're sitting in a group of anywhere between 6 to 10 people, there are 2 facilitators. Long story short, there was no significant difference in the clinical outcomes or satisfaction ratings between these conditions. Both of them improved the things that they were supposed to improve, but the pattern of improvement was indistinguishable between them. So one thing that we tested was whether people actually commence treatment, right? After randomization, people complete baseline assessments. After randomization, they get an envelope that tells them either contact the mobile health support specialist or contact the RAP team to get going with your first session. After that, the mHealth specialist helps them install the app. The RAP facilitator brings them into a session, right? Just at that inflection point, 90% of people who are assigned to the mobile health actually go on and use it at least once. Only 58% of people in the group ever make it to the clinic for a single session. And so that means that regardless of the content of the intervention, we're not even getting to the content level, we lose close to half of our audience right then and there when we ask them to come to a clinic. And that pattern of superiority of focus engagement continues throughout the study. So that is a broad, I think, lesson for mobile health. This is not focus specific because people had no exposure to focus before they started in the study, and they knew there was equal chance and equal enthusiasm to administer both interventions. So significant but non-distinguishable improvements on depression and in general psychopathology, and improvement in recovery, and satisfaction ratings were practically identical for both interventions, even though they were dramatically different in terms of the format that we deliver. Okay, last batch of interventions. This is where the fancy pieces come in. So behavioral sensing and signal detection, we have a system called CrossCheck that was generously supported through NIH's Eureka program, which is meant to support high-risk, high-reward research. So the idea here is that we collect everything, right? We try to capture, we get self-report just like in Focus. We also look at app use and call and text traffic and GPS data, and we spark up the microphone to capture ambient sound and use language processing software to determine whether someone is in a social environment or not. All that's uploaded to remote secure servers, and we get the output, right? We're trying to model to see what we can make of this and try to prevent hospitalizations. So we use GPS, we repurpose GPS here to give us these indicators of geospatial activity, right? The distance that an individual might cover throughout the day, or the time that they spend at a particular location. So when it's outside, we can see the amount of time that they spend in these general locations, but we've also conducted this research on inpatient units, right, with severely ill individuals in New Hampshire Hospital. And there to get location, we placed Bluetooth beacons in the different rooms on the inpatient unit. And so depending on the signal strength, when they were responding to questions, we can determine where you were. And the objective of the study was to see, was there a relationship between proximity to the nursing station and violent ideation and behavior? There isn't. There wasn't. Accelerometry, we can determine, as you all know, whether someone is walking or running or cycling, but from my perspective, really the proportion of sedentary time is probably the best predictor of how well they're doing overall. We leverage the microphone that will spark up every 2 minutes, and it captures ambient sound. It does the processing on the fly. So we don't record the actual spoken word, we just draw inferences right then and there. Is a conversation happening? And if so, how long is that conversation? Conversation frequency and duration. And then we have a combination of sensors that give us these models of sleep duration. And the phone doesn't need to be with someone in bed, it just needs to be in the room. And we'll do the rest. So how does this actually look? I'll give you examples from 3 patients with schizophrenia. We deployed this for a year, the CrossCheck system. And so the blue lines represent a psychiatric hospitalization, the very thing that we're trying to prevent. And so if you look at patient number 1, you see in self-reports, these dots represent self-reports composite scores that are captured every 3 days. The higher the score, the better someone's doing. Okay? So we see this pattern here. They're not completing self-reports for the first 50 days or so, and that's when they get a call from our research participants saying, don't forget to respond to self-report questions. And so there's some variability over time, right? They have better days, they have worse. There's an overall somewhat downward slope here, but they have better days, and then something happens here. They really dip, high symptoms, poor functional, high functional impairment, and that happens right before they're hospitalized. And so this person has good insight to their experience, and they're telling us with their self-report, I am not doing well. And then they're hospitalized for several days, and then as they're treated well and back on their medication, they ascend, right? They're back on track. So in this case, the fancy sensing is not necessary, right? The self-report really does the trick. But that's not the case with this person. So here, if you look at their self-report, they're either remarkably consistent in their experience, or they're just tapping through because they don't care or don't have time or they're not engaged. So if we were to just try to determine how they're feeling from this, we'd get nothing. But this person was hospitalized for a while here. And so when we look at their sensor data, we look at the hours that they spend at their primary location. So we model whether they are in a primary, secondary, tertiary location. And so here, there's some variability in the hours that they spend throughout the day in what probably is their home. Here, they stopped using GPS, and so we're not getting any data. Right? So this is a blind zone for us. Again, that's when the RA calls and says, can you make sure that the GPS is on? We're trying to do this, that, and the other. And so, again, here there's some changes in variability in the time that they spend at home. Sometimes they're there the whole day. Sometimes they're there for only half of it. And then something happens here. So here's when we start getting ratings that they are somewhere else. They're not home anymore. And so we don't know whether they're moving or they're homeless or something happened. It's not that we're not getting data. We're getting data that was showing us that they are not where they spent their time here. And once that housing situation has changed, it's going on for a while, and they wind up in the hospital. And we never would have seen that just based on the self-report. Last piece, and again, I told you we look at them, I'm kind of picking and choosing examples here from our sample. So this is device activity between midnight and 6 a.m., the times that we would typically expect people to be asleep. And so are they using apps? Are they online? Here, we see this person has very little device use, right? They're asleep. Here, they're awake, asleep. They're awake for a few hours. Keep in mind, once you start an app, it stays active for a while. That doesn't mean that the person is actually online. It means just that these functions are running on their phone, right? But we can tell their activity, and here they start using it a lot. They are clearly much more active between midnight and 6 a.m., doing all kinds of things with their device, definitely not sleeping. And so that change in sleep pattern emerges here. Again, not a good indicator for them. They wind up in the hospital for a while, and then when they're discharged, their sleep stabilizes again. Well, again, we don't know that they're asleep. We're inferring sleep, but we know that they're awake using their device much less. So it really depends on the individual, right? What their sensor pattern would be, what the relationship is with self-report. So what is the conceptual idea here? What are we trying to do? We get these mess of sensors, which are very, very difficult to model with some sort of a priori hypothesis. That's not what we're looking for. What we're looking for are meaningful events, whether it's a hospitalization, a self-reported symptom exacerbation, arrest, suicide attempt, the thing that we're trying to prevent. And then we work back from that, trying to identify what are the unique behavioral patterns, what are the anchored sensor streams that are this person's unique relapse signature. And that's what we start hunting for, right? Once we have that, for each individual, we try to see whether we find another spot in their data where the pattern emerges, starting to emerge again. And when we find that, the next time around, we're not so passive, right? So we will communicate directly with the individual, we'll give them feedback, we'll encourage them to reach out if they're having difficulties, but we'll also talk to their clinical team. In this case, it's Zucker Hillside Hospital in Long Island, and tell them, if you haven't been in touch with Joe lately, now might be a good time to reach out to him because he's showing signs that are not all that different from the last time that something bad happened. Okay, so where is all this heading? Good for time. If you think of where we're really focusing our efforts in the mobile health, the mental health territory right now, we're really at this stage, right? We recruit participants that are already identified as having mental illness. They've probably been getting services for years and years. They volunteer for our projects, and that's where we deploy this. But we're missing opportunities here, right? Part of this is because it's such a novel field. And so the risk for psychopathology emerged before we're even around, right? If we have parents that are substance users or that have mental health problems themselves, that is an opportunity for intervention, perhaps for mobile health interventions, right? Whether it's parenting skills or mental health promotion, certainly during that phase, the childhood and teenage years when we're thinking of psychosis, what we call the prodromal phase, where people aren't quite showing full-on psychotic symptoms, but there are definitely some patterns and soft indicators that their thinking and functioning is deteriorating, is becoming different, right? And so we can deploy preventive strategies here. Certainly, we can try to tailor some interventions for that first episode, which is not the same as chronic illness management, right? There are a lot of identity issues that emerge during the first episode where people are grappling with this notion that they might have a mental illness for the first time and might be resistant to this idea or might be extremely scared about the future. And then beyond where we deploy it currently, there's also the stage of building on their strengths, right, and supporting their wellness and recovery with things like vocational rehabilitation and support over time to prevent looping back to these episodes. And so there's some work emerging both in first episode psychosis and vocational rehabilitation, which is quite exciting, but it's all really, really new. Okay. So a quick word about how we think about mental illness, and I think that the RDoC framework at NIMH is a really useful framework. So far I've been talking about diagnoses, right? Schizophrenia, bipolar disorder, depression. Really, what we're thinking about more and more in the field of mental health research is thinking about mental illness as a combination of dimensions. We all have these dimensions. And the designation of whether someone is ill or not is not this bucketed diagnostic system, because we see that both the behavioral and the genetic and the symptomatic experience of people with schizophrenia and bipolar is sometimes not all that different, and that there's some overlap between autism spectrum disorders and schizophrenia, and so on and so forth. People with schizophrenia get depressed. People who are depressed experience anxiety. And so the RDoC is a framework for this new approach, this new dimensional approach to examining mental illness. It integrates levels of information, and it really goes all the way from genomics and circuits to self-report, to those kinds of things that we were looking at earlier on, and to explore the basic dimensions of functioning that span the full range of human behavior from what we would call normal to abnormal. And the idea here is that there is no real normal and abnormal. There are people who seek and need care and people who don't, and that might change over time, and it might change within individual. And so we have some studies looking at mobile health among people who hear voices. The vast majority of them don't identify as people with schizophrenia and never need care. And so we're looking at people who are, in terms of their functional impairment, are low, and in comparing them to people who are high. I'd really encourage you to check out that framework, because I think there's more and more energy at NIMH and really around the world around similar models. This notion that our ideas of what constitutes a mental illness is not exactly the way that we've been thinking about it so far. The heuristic value that we get out of the DSM, the Diagnostic and Statistical Manual, is perhaps running its course in some ways. Okay, so final words about new directions. Our team, I think, and others are certainly more interested in global mental health activity. And so we've done some research in the West Bank and East Jerusalem, evaluating whether this is even fertile ground for mobile health interventions or not. We know that it's fertile ground in terms of limited access to resources and a very complex geopolitical situation that really gets in the way of people getting mental health care, and conflict, right, which we know dramatically increases the chances that people will experience psychopathology, PTSD and depression and other problems. And so we wanted to see whether people have access to mobile devices. Do they have an awareness of mental health conditions? Are they open to using mobile technologies for interventions? So we surveyed close to 300 Palestinian adults living in the West Bank and East Jerusalem. And in terms of the survey results, the vast majority of them own mobile phones. Most of them were owners. There were no differences between males and females in terms of their access. They had reliable electricity, reliable Wi-Fi. almost all of them reported using Facebook and WhatsApp and Twitter. So in terms of the infrastructure in place, totally, they're on board. And then the majority of them reported that over half of their community struggles with mental health problems. And when we asked about specific types of interventions, we showed them demos on devices. People were open to texting with their clinicians, to smartphone applications, to tech support, to web-based interventions. And so as our programs of research mature, and we're thinking more and more about implementation, broad implementation of mobile health interventions that seem to be potent rather than just development, I'm certainly interested in deploying this on a large scale in our state of Washington as a proof of principle for the rest of the country, perhaps, that we can do this with real-world clinics on a large scale. But I'm also thinking about low and middle income countries, right, where we know that the treatment of people with serious mental illness is abysmal. So folks with schizophrenia in Ghana will often wind up chained to a tree or a concrete slab for months or years at a time. For a country of 29 million, there are 47 psychiatrists. The vast majority of folks there get care from traditional and faith healers that have little to no understanding of mental illness, and sometimes do things that really constitute gross human rights violations. Right. So I'll end this with a quick video that we captured in Ghana in my last trip, and maybe we'll stop there.
Ghana, like most of West Africa, is facing a real mental health crisis. The gap between the enormous need and services is filled by traditional healers and prophets and other spiritual advisors. Oftentimes, this treatment comes with a host of human rights violations. We see people who have behaviors that are just difficult to contain, chained to trees or to concrete slabs in prayer camps for days, weeks, months, and even years at a time, forced confinement, forced fasting. They're not doing it as a punitive action. Even the traditional healers who engage in these practices are extremely interested in alternative solutions. In West Africa, there may be a gap in terms of access to mental health training and mental health resources, but there's certainly not a gap when it comes to the penetration of mobile devices. My area of research is mobile health tools in the study, assessment, treatment, and prevention of mental illness. Adopting the models that we used in the United States, I can easily imagine developing tools that are patient-facing, texting interventions, or smartphone apps that provide resources that are easy to understand using simple language or video, stigma-busting content, and practical skills to manage distress. Things that might support the providers, individuals who grow up in the field and who might not have the training and expertise to manage complex mental health conditions. We're moving less and less from written interventions into audio and video-based interventions, and those are accessible to everyone. Keep in mind, half of the people that we showed this to, half of the traditional healers, were illiterate. When we talked to them about trying to leverage their personal mobile devices as an instrument to get some sort of support that would allow them not to engage in these practices, across the board, they were remarkably open and interested in this. We've really seen an enormous amount of enthusiasm for the type of mobile health and mental health work that we do. The types of tools that we've developed in the United States can't just be taken and plopped down in the region. There needs to be contextual influence. We need to understand the appropriate languages, the behaviors. Ghana is the ideal site for this first foray into this world. I think that the will is there. I think the capacity in terms of the technology is there. We just need to do it.
All right. So hopefully we can take on challenges in low and middle income countries, not as an endpoint after a long sequence of development in the U.S. and in the developed world, but simultaneous development. Right? There's no need to wait years and decades before we decide that it's time to deploy this. The infrastructure and abilities are there. Guys, thanks for your attention. I appreciate it.